Hello, everyone, and thank you for joining today's briefing on recent trends in coverage, enrollment, and affordability, part of the Alliance for Health Policy's 2022 Policy Roundup series. I'm Sarah Dash, President and CEO at the Alliance. For those who are not familiar with us, welcome. We're a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. Today's briefing is brought to you in partnership with the Commonwealth Fund. And you can join today's conversation on Twitter using the hashtag AllHealthLive and join our community at All Health Policy, as well as on Facebook and LinkedIn. Today's briefing, which will be 90 minutes, includes a question and answer session at the end of our speaker presentations. Please be active participants and get your questions ready. You'll see a dashboard on the right side of your web browser with a speech bubble icon that has a question mark. You can use that to ask your questions at any time, and we'll collect the questions and address them as many as possible during the broadcast. Finally, you can also chat about any technical issues you're having, and somebody will try to help you. So to start today's conversation, I am very pleased to invite Dr. Sarah Collins to join us on screen to offer some opening remarks, as well as recent data on coverage and affordability and enrollment trends. Dr. Collins is Vice President for Healthcare Coverage and Access at the Commonwealth Fund. In her role, she leads the fund's national program on health insurance and has overseen several important national surveys on health insurance coverage, in addition to authoring numerous reports, issue briefs, and journal articles on health insurance coverage and policy. Sarah, welcome. It's great to see you.
Thank you, Sarah. And on behalf of the Commonwealth Fund, I'd like to thank the Alliance for convening this briefing today and the panelists for taking time to share their expertise. I'm going to just share a few data points from some recent research on trends and affordability in private health insurance. Next slide, please. Employer coverage continues to be the backbone of the U.S. health insurance system, ensuring more than 160 million workers and their families. Healthcare cost growth is the primary driver of growth in private insurance premiums, and by extension, what people and their families in employer plans contribute to their premiums, as well as the deductibles they face. Over the last decade, in most years and in most parts of the country, these costs have risen more quickly than the incomes of working families, which means these costs are taking up a larger share of household budgets. Last week, we released a study that found that premium contributions and deductibles for people enrolled in employer plans amounted to an average of 11.6% of U.S. median income in 2020, up from 9.1% a decade earlier. Next slide, please. In 37 states, average premium contributions and deductibles amounted to 10% or more of median income in 2020, up from 10 states in 2010. These costs ranged as high as 19% of median income in Mississippi. Next slide, please. Years of research has shown that cost sharing, when someone uses their insurance and their deductibles, are critical determinants of people's access to healthcare. High out-of-pocket costs and deductibles lead to delayed or avoided care and medical debt when people do get care. The Commonwealth Fund has created a measure of underinsurance, which measures the amount of someone's out-of-pocket spending, excluding premiums and deductibles relative to their income. The biggest growth in the share of people who are underinsured over the last decade has occurred in employer plans. This is the turquoise line on the chart, or the gray line on this chart. About 1/4 of people in employer plans are underinsured by our measure. This is up from 19% in 2020. But you can see that the underinsured rates continue to be high in the individual market, despite the reforms of the Affordable Care Act. About 2 of 5 people are underinsured. The ACA's cost-sharing subsidies help a lot, but they're limited to lower income enrollees in the marketplaces. A lot of people in this market simply have really high deductibles. And I'll stop there and turn it back over to Sarah. Thank you.
Great. Thank you so much, Sarah, for those opening framing remarks and that really helpful data that you shared. And I'm looking forward to hearing more of your thoughts in our Q&A. So, okay, oops, I wasn't sharing my webcam. Sorry, guys. You would think after 3 years of this, we would have figured it out. But now I'm pleased to introduce our expert group of panelists for today's event. Joanne Volk is a research professor, founder, and co-director of the Center on Health Insurance Reforms, or CHIR, at Georgetown University's McCourt School of Public Policy. At CHIR, she directs and authors research and provides technical assistance on state and federal regulation and legislation governing private health insurance, including health insurance marketplaces established under the ACA. Kevin Patterson serves as Chief Executive Officer of Connect for Health Colorado and previously worked in the public sector as Chief Administrative Officer and Interim Chief of Staff to Governor John Hickenlooper. Kevin graduated with a BA in teaching from Sam Houston State University and holds both a Master's of Public Administration and Master's of Urban Regional Planning from the University of Colorado at Denver. Annette James, chairperson of the Health Equity Work Group at the American Academy of Actuaries, has over 25 years of senior level actuarial experience in both the private and public sectors. In addition to her service in the American Academy of Actuaries Health Equity Work Group, Ms. James is currently a member of the board of directors of the American Academy of Actuaries, a member of the Health Practice Council of the American Academy of Actuaries, as well as chair of the health committee of the Actuarial Standards Board. So if you're looking at being an actuary as a career choice, I think Ms. James can have a lot to share with you, and we're looking forward to your comments today. And finally, last but very much not least, we are thrilled to introduce Elizabeth, or Liz Rowe, who is a principal at Levitt Partners, where she develops and manages complex multi-sector alliances and advises and informs clients on the impact of federal and state healthcare issues. She also provides strategic counsel to emerging business, investment, and technology players in the healthcare sector. And as you will hear, and as we'll be sure to discuss, Liz was also a senior member of the Health Education Labor Pensions Committee staff under Chairman Alexander. So welcome, Liz. So Joanne, we're going to start with you. Can you lay out for us, what are the current trends in enrollment? Where are there opportunities to not only enroll eligible beneficiaries in coverage, but also to potentially make the coverage more affordable? Joanne, looking forward to your remarks.
Yes, thank you, Sarah. This is a timely convening. This is 1 week coming off of a historic open enrollment period for healthcare.gov. And some state-based marketplaces are still going strong. Kentucky is still open until the end of this month, and Maryland through the end of February. But to date, 14.2 million people have enrolled in marketplace coverage, including 10 million through healthcare.gov and 4.2 million through the 18 state-based marketplaces. Most are returning customers, not new enrollees, but the 6-month COVID SEP that was in effect last year brought in new consumers. States had some challenges in getting out the word on the new enhanced premium tax credits available under the American Rescue Plan Act and the additional targeted assistance for the unemployed. But together, state-based marketplaces and the FFM brought in 2.8 million new enrollees last year during the special enrollment period. So how did we get here with those big numbers? For one thing, the administration significantly increased funding for navigator assistance, quadrupling the number of navigators that are available to help people enroll in coverage, and spent $100 million on advertising for the COVID special enrollment period. In 2020, 12 of the then 13 SBMs opened up their marketplaces for their own COVID special enrollment period when healthcare.gov remained shuttered. And states have been experimenting with novel ways to reach the eligible but uninsured. One path that I want to talk about a little bit today is to leverage the tax filing process to notify individuals of their eligibility for marketplace subsidies or Medicaid. Maryland was the state that first adopted this program. Their Easy Enrollment program uses state tax filing forms to ask Marylanders if they want to share their insurance status, income, and other relevant information to receive an eligibility determination for Medicaid and subsidized marketplace plans. The marketplace will then notify those taxpayers of their eligibility for coverage and, if applicable, offer them the opportunity to enroll in a marketplace plan outside of the open enrollment period. Of course, Medicaid is open year-round for enrollment. In the first year of that program, 2020, 60,000 people shared their data, and most of those, 53,000, were deemed eligible for marketplace subsidies or Medicaid. A much smaller share enrolled in coverage, just over 4,000 people, but the program predates the enhanced subsidies under the American Rescue Plan Act. So it's, affordability was still a barrier for people enrolling at that point. But it may be a successful strategy for reaching those who have proven harder to reach, because of those who did enroll, 23% of marketplace enrollees were Black, compared with fewer than 17% who enrolled during the open enrollment period, and a disproportionate share were younger enrollees, ages 18 to 34, 40% compared to 28% during a regular open enrollment period. Other states are implementing their own version of this. Colorado, Pennsylvania, and Washington have something in effect. And California plans to implement their own version of this that goes a step further. Their marketplace plans to automate marketplace enrollment for people losing Medicaid, and the new process, which will take effect later this year, will automatically enroll those who are eligible for marketplace subsidies into the lowest cost silver plan available, or the same managed care plan they had as a Medicaid enrollee. Looking ahead, healthcare.gov will be back with the same expanded open enrollment in effect this year, running through January 2015, which is longer than we've had in recent years, plus a new monthly opportunity for low-income individuals to sign up for coverage with a new SEP for those under 150% of poverty. In the months ahead, states will be working on the unwinding of the public health emergency in which people remained continuously enrolled in Medicaid. Once that ends, there'll be new redeterminations of their eligibility, and it will present enormous outreach and enrollment challenges to be sure that people coming off of Medicaid make their way to marketplace plans with the appropriate subsidies. A projected 15 million people will be terminated from Medicaid when we unwind this current continuous enrollment program, and it's estimated that about 1/3 of those will be eligible for advanced premium tax credits. We at CHEER are going to be writing about the California experience and fielding a survey of SBM directors in the months ahead to get their thoughts on these challenges and others. Turning now to affordability, another major barrier to getting the eligible but unenrolled into coverage. I'm going to have to start by recognizing what the American Rescue Plan Act has meant for marketplace premiums. People with incomes under 150% of poverty pay no premiums, and people with incomes above that pay much less than they have in the past. ARPA also extends subsidies to those who had previously fallen on the other side of the cutoff or cliff at 400% of poverty, so that no one now has to spend more than 8.5% of their income on a plan. This is in effect still. The enhanced subsidies have made it possible for people to buy up to richer gold and platinum plans, in addition to the cost-sharing subsidies for those under 250% of poverty. And there was targeted help for the unemployed, as I mentioned, through 2021. It's no longer in effect. People claiming unemployment insurance qualified for zero premium marketplace plans. About 200,000 people enrolled into this provision, and 34,000 of those are people who would not have been eligible because they were in a coverage gap state, a Medicaid coverage gap state, so they were newly eligible for coverage with substantial subsidies because of the unemployment insurance program. There are other programs I'm going to talk about today that we've done some research on, and I'm going to share some resources when this is done that I know the Alliance can share the various posts that talk about the states that have done these programs and provide more detail. But there are some states that have provided their own state funding to beef up subsidies. California has their own program to enhance the tax credits for those under 400% of poverty, and extended premium tax credits to those above 400% of poverty, going up to 600% beginning in 2020. Massachusetts and Vermont also subsidize premiums, and Minnesota subsidizes coverage for those not eligible for premium tax credits, Medicaid, or their basic health plan. Another tool that states have used to tackle affordability of coverage is standardized plans, which sets cost sharing for targeted services to provide pre-deductible coverage for key services and prioritize co-pays over co-insurance to make access to care more affordable. 8 states plus the District of Columbia have standardized plans. Colorado will use them beginning in 2023. And the administration has proposed to require standardized plans be available through healthcare.gov beginning in 2023 with the Notice of Benefit and Payment Parameters rule that's out for comment right now. DC is using their standardized plans to target lower cost sharing to treat diseases that disproportionately impact DC residents of color, diabetes and cardiovascular disease, and Colorado will follow suit when they roll out their plans in the coming year. And standardized plans are part of the Washington and Colorado public option programs. And as previously noted, ARPA extended premium tax credits to those with income above 400% of poverty. Prior to ARPA, states relied on state-run reinsurance programs to lower premiums for unsubsidized individuals. 14 states have reinsurance programs that offset insurer costs for high-cost individuals and have used 1332 waivers to pull down federal savings in premium tax credits to help fund those programs alongside their own state funding. And finally, states have opportunities to improve how coverage works by adjusting what is covered under their essential health benefit benchmarks. States have used some flexibility allowed under the federal rules to update their benchmarks to improve coverage. Most recently, Colorado clarified and affirmed coverage for gender affirming care. Beginning in 2023, plans must cover medically necessary care to treat gender dysphoria. And requires insurers to be more explicit and more comprehensive in their coverage. Previously, 5 states similarly updated their essential health benefits benchmark to improve coverage, specifically to respond to the opioid crisis in Michigan, New Mexico, Oregon, and Illinois. And South Dakota updated their benchmark plan to cover ABA therapy for autism spectrum disorders. This is made possible under the flexibility that allows states to update their benchmark plans so long as the generosity of the benchmark does not exceed the most generous of the 10 benchmark plan options they had to choose from. So it's actually proven to be a tool to enhance coverage in those states. Looking ahead, one thing that Congress is debating now is realigning the firewall, the employer firewall that keeps people who have employer-sponsored coverage from accessing premium tax credits if their coverage is considered affordable and meets minimum value. Currently, the bar is still set at requiring premiums be no more than 9.83% of household income. There's a proposal to lower that to match the 8.5% cap on premium contributions in the marketplace so that more people could clear the firewall and get out of unaffordable employer coverage to access premium tax credits. And finally, there's still hope that there'll be a fix to what's called the family glitch that prevents dependents from accessing premium tax credits, regardless of whether or not their own coverage is affordable. If the self-only coverage for the employee and the family is considered affordable under that firewall test, the family cannot access coverage. 6 million people are denied premium tax credits under that rule, and there's hope that there'll be an adjustment to that interpretation so that people can access premium tax credits when they have unaffordable dependent coverage. And that's a quick overview of some of the activity in the states to reach the eligible but uninsured and to improve the affordability of coverage.
Thank you so much, Joanne. And that was definitely a tour de force. Let me ask you, first of all, I hope this is all written down somewhere so people can see where this menu of options may be, but really appreciate this. I want to ask you before we shift to Annette's presentation, you mentioned a lot about the states and the state-based marketplaces. Like, just for those who might be kind of a little bit newer to the trajectory here, are there big differences between like what can happen in states with the state-based marketplace as opposed to states that have the federally facilitated marketplace? Like, are there any major parallels or overlaps, or can you say a little bit about the different levers that are available from a policy perspective?
Yeah, state-based marketplaces have much more autonomy to set their rules and to do their own outreach and enrollment. So for example, as I said, during the first year of COVID, the state-based marketplaces, all but the Idaho marketplace, enacted their own state special enrollment period to allow people to enroll in coverage outside the open enrollment period so more people could have coverage during the pandemic. The feds refused to open up the marketplace, even for states that were relying on healthcare.gov. There were governors calling on the healthcare.gov to be open in the same way. So in that case, states had flexibility to open up their marketplaces, where the states relying on healthcare.gov were sort of stuck with a federal decision. They also run their own outreach and enrollment programs. So, you know, in the years where prior to the current administration, there were substantial cuts, 90% funding cuts in Navigator funding and 80% cuts in advertising. And though they do their own advertising, they really said they sort of rode on the wings of the federal advertising program, and they sort of also experienced difficulties in getting the word out when there was less funding from the federal level. But nonetheless, they do fund their own advertising and enrollment assistance, and have been more, you know, have really tried to be creative about how to reach eligible but unenrolled, including some phone calls in some cases, and other programs, like I said, leveraging the tax system or other programs like unemployment or family benefit programs that find people who might be eligible for marketplace subsidies.
Great, thanks for that additional context. And so now we'll turn to Annette James, and Joanne has done a great job of sharing a lot of the mechanisms by which people can get coverage, went a little bit into EHBs. And so Annette, so pleased to have you here. Tell us more about how premiums, how plan benefit designs actually impact affordability, and how is that affecting the health equity conversation. So Annette, I'll turn it over to you. Thanks for joining us.
Thank you so much, Sarah, and thank you so much for inviting me to be part of this panel. Before we go into, can we get the next slide? Before we go into premiums and how they're determined, I'd like to spend a moment talking about what an actuary is, because I don't want to presume that everyone knows what an actuary is or what they do. And so for the purpose of level setting, I thought I'd start there. So actuaries typically spend a lot of time analyzing risk and modeling the financial impact of those risks based on the likelihood of future scenarios. And actuaries traditionally have worked in insurance, all lines of business, life, health, property, and casualty insurance. They also work in non-traditional industries such as financial services and the environment and issues such as climate change. So let's talk about health actuaries and how we fit into the health ecosystem. So actuaries work with health plans. They work with to determine premiums and to set reserves. Those are the traditional roles of actuaries. And setting reserves is really a way to ensure that the health plan has sufficient funds set aside to meet its obligations. We also work with health plans on other issues. We're often in the room when a lot of discussions and decisions are made regarding designing of benefits, care management programs, provider contracting arrangements, provider networks, and so on. So we usually provide the quantitative analysis to support those decisions. Actuaries also work with federal and state governmental agencies and programs. So we're talking about Social Security, Department of Labor, CMS, the Center for Medicare and Medicaid Services. And they manage social programs and develop regulations and legislation. As a full disclosure, I myself worked with this as a regulator in the state division of insurance in Nevada for many, many years. And we're also involved in other aspects of health. For example, actuaries are often employed by provider groups taking on insurer risk, pharmaceutical companies and pharmacy benefit managers and so on. So hopefully that gives you a little bit of background as to what an actuary is and how we fit into the health ecosystem. So next slide. So let's look at setting health premiums. There are generally three components. The first is the largest, and that's the cost of benefits for the individual and small group market, this portion is required to be at least 80% of the total premium. And premiums are set on a projected basis. So this portion is the expected level of claims. And so actuaries will estimate the expected level of claims, and it reflects the cost of providing services net of patient cost sharing. And so it's impacted by many different things. It's impacted by the extent of the network. Is it a narrow network? Is it a broad network? Provider reimbursement rates, what type of utilization management protocols are in place, as well as the types of benefits that are offered. The second bucket is what I call the non-benefit expenses, and so that's administrative costs and taxes and fees. So it includes things like premium tax, salaries, and so on, the cost of administering claims, and other expenses. And the third bucket is premium and tax and risk margin, and this is usually the smallest of the three. But the one thing to note here is, as uncertainty increases, this bucket will increase, with not necessarily a decrease in the other two buckets. So for example, with COVID, this is where a lot of insurers added some risk margin to their premiums to reflect the fact that there was a lot of uncertainty as to what the impact of COVID was going to be. So next slide. So now I'm going to talk a little bit about trends, and Joanne talked a lot about some of the things I was going to cover here. So I am happy to expand on anything on this slide in the Q&As. But what I'm seeing is an increased focus on health equity issues. As we all know, the pandemic shone a bright light on health disparities, and so both from the governmental perspective, federal and state governments, as well as health plans and employers, we're seeing a lot more emphasis on health equity issues and an attempt to address disparities. On the next slide, I will give a brief summary of what the actuarial profession is doing in this regard. There's also, I'm seeing an increased focus on behavioral health. Again, in response to what's to the pandemic and what we've seen with behavioral health utilization increasing during the pandemic, a lot of states are definitely focusing on behavioral health. Access and affordability are always areas that there's a lot of focus on, as far as do consumers have access to healthcare and health insurance, and of course affordability. As far as equitable benefit design, Joanne talked about the interest in standardized plans, and we're also seeing interest in benefit designs that are focused on certain subsegments of the population. Next slide. So now I want to talk a minute about what actuaries are doing in the health equity space. So the American Academy of Actuaries established the Health Equity Work Group in the fall of 2020, so that as actuaries, we could add our voices to the health equity conversation in a meaningful and appropriate way. And as I mentioned before, actuaries often have a seat at the table when many decisions are made in the health ecosystem. So our main focus is to work on solutions by first taking an introspective view of the common analytical practices that are used by actuaries in the context of health equity. So in other words, when we're sitting at the table, are there things that we can do differently to enhance health equity? So there are four bullet points here, and I'll focus on the first two. These represent four phases And right now, the first phase, we're in the first phase, which are identifying, actually, we just finished the first phase, identifying and monitoring actuarial data sources and methods that may contribute to health disparities. So we spent a lot of time trying to identify the right questions to ask. And as a result of our inquiries, we published 5 discussion briefs. We will now start in the second phase, doing an analysis to see what existing research, what research exists, and where there may be gaps to have additional research. And in this regard, we sent out a request for information, and it's due back on February 15th. So if anyone in our audience has information that may be helpful to the areas of our inquiry, I'd be very interested in hearing from you. The next slide. I wanted to give an example of how we're looking at health equity. And this example focuses on benefit designs and the common benefit design strategies that are used today and how they may impact disparities. So in this picture, we have individuals and families at the top of the page attempting to access the healthcare system, which is shown at the bottom of the page. And in the middle, we show some benefit design features inside of a fenced-off area. And these features are intended to discourage overuse of healthcare services. But the questions we are exploring are whether some of these design features could actually create or perpetuate barriers to access for disadvantaged communities and result in underutilization by those communities. So as we look at the fenced-in area, some of the questions we're exploring are on the right-hand side are high deductible plans so cost prohibitive that they inadvertently discourage appropriate use by certain populations. On the left, can the pre-authorization and pre-certification processes increase reluctance to seek needed services in some communities due to the invasive nature of these protocols? And in the middle, could a tiered network design actually discourage appropriate use of medical services and result in further underutilization, especially if first-tier providers are not readily accessible to disadvantaged communities? So as I've indicated, these are some of the tough questions that we're exploring regarding benefit design and health equity. And we're actually looking at similar questions in each of the other areas that we're exploring, in the area of pricing, provider contracting and network development, as well as population care management. Next slide. So I mentioned that the 5 issue briefs that we have published, and there are links to each of these. And we also, as I said, we just issued a request for information to solicit input on existing and ongoing research that may help the work that we're doing. It's because it's important for us to collaborate with both partners. And finally, if you have any questions, here is the person to contact, and I'm happy to answer any questions in the Q&A section.
Great, thank you so much, Annette. I really appreciate the thoroughness of your presentation. And we do have a question from the audience I would love to ask if in follow-up. And this is, I'm just gonna read it because it's fairly technical. But the request is whether you could address the question of what a risk margin is. And the questioner says it's often misunderstood as just a kicker for profit. Can you share more about what that is and sort of how do actuaries balance this tough job of kind of projecting the future and sort of like trying to get it right, but maybe not always getting it right? So a lot packed in there, but that is from our audience.
Yes, that's a great question. So a risk margin really reflects the amount of uncertainty, and it's not you articulated correctly. A lot of people think it's just additional profit. that's not the intent. The intent is that when you project anything, when you project costs, there is uncertainty, and there is a range of uncertainty that's implicit in that projection. If there is additional uncertainty that probably be as a result of regulations or legislations or something like COVID, that is really difficult to predict. And it was not contemplated when the initial projections are done, or the uncertainty became more apparent after the initial projections are done. Then there is the risk margin is added to reflect that uncertainty.
Thank you very much. It's very helpful. So it's fair to say the more uncertainty, the greater the risk margin, and you've got to kind of adjust accordingly.
Absolutely, and the higher the premiums, right?
And then the higher, yes, indeed. Well, thank you so much, Annette. Look forward to the Q&A. And now I will turn to Kevin Patterson. Kevin, who runs a state-based marketplace in Colorado, and I think you have the tough job of trying to explain all this to the public and to your customers, all this wonky stuff. So we are really looking forward to your presentation on how this actually works in practice in your state.
Yes, Sarah, thank you. I really appreciate the opportunity to be with you all today. The meeting right before was a lot of this conversation with our Health Insurance Affordability Fund, where I'm working with our Commissioner of Insurance to actually put up some state subsidies. We've been able to roll out a cost share reduction for a targeted population, and we're looking to expand that into the family glitch and possibly those that are regardless of immigration standards, so they could also come up with a number of different health affordability choices that would give them the ability to have state funds that help them. But in terms of what we do at the at Connect for Health Colorado, we of course implement the Affordable Care Act for our state. You know, the thing that has been the biggest challenge, especially lately, is just when decisions are getting made, especially at the federal government or not, and not just about what the policies are, but when it happens, really has a huge impact on our ability to move and try to respond very quickly to a change at the federal level. The great thing about being a state-based marketplace is that we are able to use a lot of the flexibility that Joanne talked about to do a number of the different programs that we are actually in the middle of right now. Of course, she talked about the COVID SEP that we did last year. We extended that at the request of a county, metro county here in around Denver, that wanted us to give folks enough time because they noticed that folks were getting layoff notices, and we were able to move that time for them. We spent much of last year in some sort of special enrollment plan that was happening, and we've just issued a new disaster special enrollment plan that is allowing folks that from the fires up in Boulder County to make sure that they can actually put their lives together and still have time to come through and give them another 60 days because there may be documents that they can't find right now. And so we wanted to make sure that we expanded that, and for folks that are concerned about the latest surge we're seeing in our hospitals and ICU beds. We have, in fact, added a tax time special enrollment period for this current year. We've been working with our Department of Revenue at the state of Colorado. We're really excited about that opportunity to get to additional folks that will come through, whether they're Medicaid eligible or for the marketplace. We're able to get them a health affordability plan that helps them with just a simple check of a box, although the work to doing that is not simple. We also have been working on standardized plans with the Division of Insurance. There is a state bill that came last year that is moving that process through. Joanne also talked about our benefit design, adding a gender affirming care, and we're actually quite proud of that. I think the other thing that we have been seeing a good bit of is, because we are a state that is involved in reinsurance, we've been able to keep reductions in the individual market on average 20%. We've been able to save folks 2 years in a row. We also are seeing that our individual market rates have become extremely competitive to group rates, and especially for really small businesses. We've never really took off in terms of the old SHOP program, the small business plan they had for the ACA. A lot of compliance that was required for that, and a lot of these small mom and pops are just trying to make payroll and not trying to figure out how to do a complicated tax credit. But we are seeing a number of those folks, especially after COVID, where businesses were just trying to stay open, moving their employees into the individual market, and understanding, especially after the American Rescue Plan really increased the size of those subsidies. You know, it makes a really big difference to folks that are making $16, $17, $18 an hour to actually have a health insurance plan that they can pick that is a full EHB, and in some cases might be a little bit better plan that they maybe were able to get from a very, very small employer that's trying to kick in bits and pieces of money. So, you know, those are things that I think are really important for us to think through. We have been using our flexibility to try to help as many different folks with state funds and dealing with growth, and really just responding to what our customers are asking us to do. And I think that's the additional benefit, is we really can be responsive to customers, working through our brokers and assisters and our certified application centers in hospitals and doctors' clinics, to make sure that we're able to catch people when they need care and get them some sort of assistance when they can get around a huge doctor bill or a hospital bill, that they can cutting our medical bankruptcies in more than half in the state of Colorado. So with that, I'm happy to take any kinds of questions and participate in the conversation with the rest of my panel colleagues.
Thank you so much, Kevin. And I'm really glad you mentioned small businesses too, because I think from the days I think I was working on state-based health policy and campaigns back in 2005, and I know way before, that's you know, insurance for small businesses has been a real challenge. We did have an audience question that I'd love to ask and follow up, and this might lead right into Liz's presentation as well. And there was a specific question about a couple of provisions here. So let me read the question. The questioner is concerned that lowering the employer responsibility requirement without indexing to 8.5, assuming 8.5% of income, would be harmful to the small group market, and has some concerns about the impact of removing the firewall or the family glitch. Do you have a sense of what that would do to the small group market, or like when you think about the relative implications of federal policy for the small group market in your state?
Yeah, you know, when we see this movement, it's from really small businesses. It's usually 10 and fewer, and I'm using that mom and pop example because those are the folks that we're really looking at. You know, they don't have the same requirement. And what you end up with is a lot of folks that are eligible but not enrolled, but they're not getting picked up that way because people are assuming they have a job and they get employer sponsored care. So I think it's a pocket of uninsured that we really don't talk about and focus on enough for these really small businesses. And so that's where I'm seeing a good bit of that movement. And I think that's the way that you deal with the concern that I'm hearing in the question.
Great. Well, thank you so much, and we'll look forward to more discussion in the Q&A. And so now, Liz, thank you so much for joining us. And I understand you have some slides, and you have been working with an enrollment coalition, specifically focused on taking some very practical steps on eligibility enrollment. So we look forward to hearing your thoughts.
Great. Well, thanks. It is fantastic to be here, and particularly with this great group of presenters. It's just been really helpful, some fantastic information. We're going to go through these slides really quickly because I actually want to get to the panel discussion, just because I think it's going to be fantastic. So we can go through this first slide here. kind of what I tried to do was think about it. A lot of our work at Levitt Partners is done at kind of the federal policy level. We're a federal policy firm, as well as we help run stakeholder coalitions. So really tried to think about what are some of the themes that we're seeing kind of in federal policy and advocacy, and then amongst stakeholders. And so 3 things we're going to just briefly identify as kind of trends or items that we're watching is the potential for coverage cliffs. Basically action forcing events in federal legislation that could have a significant impact on enrollment, or could also kind of carry along with it other policy changes around enrollment. The second piece would be to kind of what Sarah mentioned, what are some stakeholders doing? Are there areas for consensus among a number of different enrollment strategies? And then finally, this has come up a lot so far today, is this coverage migration with the individual employer markets and looking that over the long term. So if we take the next slide, I was going to say this, Kevin, I think, made a comment about kind of one of the things that can be challenging is both federal action and inaction, as well as the schedule. And so one of the things that we have dealt with in Congress, and I was on both the Health Committee and the Budget Committee during both the Affordable Care Act, and then later on through some efforts in 2017 just to try to stabilize the individual market. Sometimes there's not a very good understanding at the congressional level that you can't just flip a switch on a number of policies, and particularly when we're talking about kind of insurance markets, and the fact that states have deadlines, they have plans in places. Health plans have a process that they go through for setting rates, setting premiums, and setting plans. And so it's really important, I think, for a number of these issues to try to not wait to the 11th hour to talk about them. Unfortunately, Congress has a tendency to wait until the 11th hour to address some of these issues. And so, one question we get quite a bit is, is there going to be legislative action on enrollment strategies, or outside of ACA expansion, when are we going to talk about some, whether it's program improvements or changes? And I think we've seen for a long time politically this focus on kind of ACA expansion or repeal and replace, frankly, that you had policymakers kind of on either side of the spectrum, but not that many policymakers kind of in the middle trying to figure out operationally how to make the current system better. And so I think some of the deadlines that we're looking at that are going to be really impactful is, number one, what happens when the ACA subsidy expansion that was part of the American Rescue Plan, what happens when that sunsets at the end of this year? Does that create a moment for potentially Congress to step in and expand those subsidies, or enact other policies in addition to try to address enrollment? As we saw, the proposed Build Back Better Act would extend those subsidies through 2025. I think that's an interesting time frame. If you look, you also have got kind of like the Medicare Trust Fund. I know that's a webinar for another day, but you have the Medicare Trust Fund approaching asset depletion around that same time. And so do you kind of create these cliff moments where you're forcing federal policymakers to actually have to look at some of these items? So we all know kind of we're in a little bit of a waiting game right now as to what's going to happen, both with the Build Back Better Act or even legislatively over the next couple months. But I think it's hard to ignore the fact that this larger federal policy landscape does have some impact on the ability to make headway. And then on the next slide, one of the things that we are also seeing is, maybe it's because of that lack of consensus at the congressional level on some areas on enrollment, that you're starting to see, not really starting, I think it's been there for quite some time, but really seeing a lot of stakeholders at the federal and state level working together to try to address enrollment, and particularly the enrollment of people that are currently eligible for plans or subsidies that aren't enrolled, and trying to get a sense of what are some of those barriers, and what are some of the strategies where you can see some consensus. So some of the issues where we've started to see some consensus bubble up, again, they're all challenging issues, but really having a focus on improving data and analysis to address health disparities, making sure that plans can actually collect the information that's going to be really helpful in measuring whether or not, benefit design is actually helping address health disparities and move forward on health equity. Agents and brokers, I think it's interesting. I think some people would be surprised to see this on the list of consensus. I think there's definite consensus that agents and brokers have a role to play in enrollment, but I think there's also an acknowledgement that any of the different players or sisters need to be working under certain standards. So I think there's a place where you could see an enhanced role maybe for agents and brokers, again with oversight and making sure that everything's being done in a way to help obviously enhance enrollment in qualified health plans. A lot of conversation we've heard about is kind of what's going to happen at the end of the public health emergency and dealing with Medicaid redeterminations. So we know there's a lot of conversations happening in that space. Another area where I think we're seeing a lot of discussion is how do you leverage investments across multiple programs? So that's essentially, how can you leverage enrollment investments on, the side of Ag Department versus HHS. So at a state level, whether or not somebody's applying for a SNAP benefit, also applying for Medicaid, how do you leverage some of those investments, whether it's on the technology side, data storage, so that you're streamlining enrollment in a really efficient way. Another issue that has bubbled up and frankly wasn't one that I was really familiar with until recently was consumer notification and consumer communication, and just making sure that plans have the ability to reach out to consumers, whether it's through text messages or phone calls, to help if there's been any kind of drop in enrollment. And then finally, this is a much more structural policy option. I think there's a lot of different ways that you could approach this one, but I think particularly after the individual mandate was repealed, there's been a lot of focus on auto enrollment as a potential enrollment strategy. And whether that's a federal program or federal standards with state implementation, completely state auto enrollment options, I think there's a number of policies there, really worth thinking through. And so one of the stakeholder, activities that are out there, we have to give it a little bit of a plug that we work with them at Levitt Partners, but we help run an enrollment coalition. And as you can see here, this just gives an example of just the really broad group of stakeholders that have come together to work on some of these issues. So I think it just gives you a sense that, one of my former bosses used to say, that when you looked at Congress, sometimes it was like split screen TV. On one side, on one channel or one side of the split screen, it was all the fighting and the debate, while on the other side there were people actually getting stuff done. And so I think this is just to show that while yes, there's a lot of focus on areas of disagreement within ACA policy, there is a lot of area where you've got folks sitting around the table trying to get things done. And then finally, just kind of, when we think about other themes that we're looking on, if you go to the next slide, one of the things that we're, paying attention to and obviously don't have any answers yet is just kind of the coverage migration that we've been seeing over the last, year or two, and really kind of the impact of COVID-19 on sources of health coverage. We know that job losses obviously led to some shifts in employer-sponsored coverage, but it's not clear yet kind of how permanent those shifts are going to be if we're in a post-pandemic world, if the employment situation improves, are folks that are in the individual market likely to stay there, or, do we think that there's going to be some type of churn back into the employer market? We've also seen, in light of COVID, some employers really taking an enhanced role in that kind of health and wellness of their employees. So that's whether or not, there were some companies that provided, COBRA subsidies when they had to lay off, additional COBRA subsidies when they had to lay off employees. We've seen, some employers create wellness clinics or, help with vaccinations and masks. So it's been really interesting to see how some employers have kind of responded in the pandemic and really taken responsibility for their employees' health and well-being. it was already mentioned before, but kind of potential legislation to weaken the ACA employer-sponsored coverage firewall. I think that's certainly a federal policy area that people are watching closely in the employer-sponsored coverage space. And how that plays out, I think, will just be, it's another factor in this story of kind of the role of large employer-sponsored coverage. And then finally, I would just say, and Annette mentioned this, and I thought her presentation was really, really helpful. There's a lot of large employers that are looking at health benefit design as a way to address health equity and social determinants of health. And again, stepping into this role of, they're large purchasers of healthcare coverage, but also healthcare services. So they're in a unique position, whether it's kind of demanding diversity, equity, inclusion training of the providers that they work with, or again, really assessing their benefits. There's a lot that large employers can do, utilizing their flexibility to be a little bit of a testing ground in some of these areas. So again, I think we don't have, hard answers yet, but I think this will be over the next year or two. One of the things that we're going to be looking at is, are we starting to see, more of a migration away from large employer sponsored coverage? Or is this kind of, maybe a shorter term trend because of some of the factors that we mentioned? So happy to get into the panel and talk further, and really appreciate the opportunity to be here.
Great, thank you so much, Liz. And so while the other panelists are turning their cameras back on, and I'll invite Sarah Collins to rejoin us. So many questions for you, Liz, and follow-up. What a really incredibly helpful and clear presentation. I just want to ask you, since you sort of ended on the note of large employers and the sort of shifts that COVID has brought about, I'm really curious from your perspective if you think, where is the status of the conversation around employers? Is it has it caught up to the changing landscape around the gig economy? I mean, how many of us have had the privilege of sitting in our houses and working from home and ordering from DoorDash or Grubhub or Instacart or whatever? So I'm just curious, how you think some of the shifting workforce landscape is factoring in, and what impact do you think, if any, that'll have on disparities?
Yeah, I think it's interesting because I think it will have an impact, and it is having an impact. And I think, again, this concept of, we've always thought about churn oftentimes with kind of the churn between Medicaid and the individual market. And I think now we may have more churn also with kind of the large employer market and then the individual market. I think it's been interesting. Some employers that we work with are still really committed and feel very strongly about the role of the employer in healthcare and health insurance. I think there are some others that still think it's really important, but they're kind of more open to thinking about other ways of delivering that, whether it's, giving somebody a subsidy to go into an individual market, or doing something that's more portable that you could take with you. So I still think it's a really interesting time, because I would have said, 3 or 4 years ago, I think it would have been a very hard and fast. We like status quo, we're not really touching it. But I think the facts on the ground economically have changed, and that has forced more of these conversations, frankly, more than any other political debate has.
Yeah, thank you. So very, very practical considerations. Well, thank you all for your incredibly helpful overview, and excited to get into the Q&A. So we've got questions coming in, and we've got about half an hour left in our panel discussion to get to them. So let me start on a really practical note with the latest question that just came in. I'm going to talk about this family glitch, which seems like it's been around forever. Was mentioned, this is a questioner that says it was mentioned that 6 million people are affected by the family glitch. They know of a Colorado high school teacher who's paying 14% of family income for health insurance. Their employer offers family insurance, but only helps to pay for the employee's health insurance, not for the husband and kids. Obviously, serious financial burden for them. What do you think, is the prospect of fixing or changing this? Liz, let me just start with you, since I know you watch this, and we'll let others chime in.
It's interesting. I feel like it's politically been on the list of like every time someone's about to do something in this space, it's kind of on the list of things that I think there's bipartisan support for. I think where it's gotten challenging is within some of the most recent legislation. As everybody knows, they're trying to come up with priorities on where they're going to spend money. And so I think that's really, I think, politically where it is it's just an issue of competing priorities.
Yeah, and I want to get to a broader question about those competing priorities, but let me ask if others have a thought to that. Kevin, since it was a question or specific about your state, do you have a thought about that as well?
I do. I think what's interesting on the family glitch is if you look around, especially as public sector employees typically fall into this category more than others. And so whether you're in a large urban area or a small rural community, it's probably one of your top 2 or 3 employers as well. And so the ability to get to that many people to actually give them the ability to actually get care. I mean, these are folks that are teachers, janitors, bus driver. I mean, these aren't folks making a whole heck of a lot of money anyway. And so their families is like, hey, great, I have insurance, but you have to go explain to your significant other and kids that, go figure it out, is a very difficult conversation for households to have. And so I think I'm actually a little more optimistic on that one than I am on a number of other things right now. But I do think that there is a way to figure that one out, because I think the benefit to it is going to be larger than most people would estimate.
Yeah, and if I may, I do want to point out there is the administration has a unified agenda of rules that they hope to tackle or plan to tackle at some point, and there's a hint that this is on that agenda. There is a regulatory fix here. It doesn't have the same outcome as if there were a legislative fix, but you could interpret the affordability test to allow for consideration of what it would cost for those dependents to get care and measure affordability against that instead of what it costs for the employee only to enroll. And so the family would end up in 2 different places of coverage. The employee would remain with the employer plan, and the dependents would be free to go to the marketplace with premium tax credits. But it's one area that states like Colorado's and others, that when they think about people that are falling through the cracks, they're thinking of ways that they can devote state dollars to that. And clearly, if it was addressed at the federal level, those state dollars would be freed up to reach other populations.
We also looked at in our analysis of employer premiums, average premiums that people were paying, and in 8 states, the average premium relative to income exceeds that 8.5% threshold. So that's an average across single and family plans. So both lowering the threshold to 8.5 and fixing the glitch would really potentially help a lot of people.
Great, thank you. And I have a question about there's a question from our audience about another provision, and so I want to ask that question. And that one is directed at Annette James, and it's whether you've considered sort of the actuarial considerations of the tax credit provisions that were in the Build Back Better Act that would be focused on low-income populations, and particularly kind of this question around like how are actuaries thinking about the challenges potentially of setting premiums for marketplace plans if the Build Back Better Act were enacted that would allow individuals with incomes below the poverty level who are currently ineligible for the subsidized marketplace coverage to gain access. So for example, in the dozen states that haven't taken up the Medicaid expansion, how are you thinking about questions of pent-up demand? Would you expect that to be substantial if that coverage gap population became eligible for marketplace subsidies? And then lastly, it's a multi-part question. What health equity issues do you think would then be affected? So if you can write a whole essay on it after this, perhaps. But thanks for taking a stab at that great question.
Okay, that is a great question, and I was keeping it in my brain, and then you went to further and further questions. I had to start writing it down. So I'm going to start with the pent-up demand question because that is certainly something that is a concern when trying to price with these changes in population. because one of the inputs to the premium level is, of course, the risk pool and what the risk pool looks like. And so the influx of new members into the risk pool raises the question of what that new risk pool will look like once these people enter. And that is also a question not just for the Build Back Better bill, but also for when the public health emergency ends, right? And a lot of people get off the Medicaid rolls and go into the commercial market. So that's a question that it depends is the only answer. It depends on the mix of people that come in. And quite frankly, the risk pool impact really depends on who are these people. Are they not only their health status and their pent-up demand, but also where do they lie on the income level? Because are they eligible for subsidies? So the impact on cost is greater for those who are unsubsidized, right, or marginally subsidized than for the folks that are heavily subsidized. And when I talk about cost, I'm talking about the cost to the consumer, because most of the cost will be taken up by the subsidies. I also wanted to kind of piggyback off of what we were talking about before, as far as, you know, states are taking up. I find that recently a lot of states are having a lot of activity around what can they do in addition to what the federal government is doing as far as subsidies, and not just in the past, a lot of the focus has been on premium subsidies and giving additional premium subsidies to those over 400% of federal poverty level. But now the focus has shifted with the ARP, the focus has shifted to cost sharing subsidies, where the focus is now on what can states do to make the out-of-pocket expenses a little more affordable for the consumers. So I think I don't know if I tackled the whole question, but yes, if there's something I didn't tackle that you wanted me to address, I'd be happy to.
Great, thank you so much. And just a reminder to our audience that our panelists have graciously, shared their contact information. That's in an expert list that we have shared with you on our website, and that also includes a number of other experts and stakeholders in this area in case folks have questions about these or related issues. All right, I want to ask the sort of trade-offs question before we move on to the next round, as we're getting some great audience questions in. And Liz, like you really talked about, it's a matter of priorities and trade-offs, and in all of these policies, right? Like we're kind of talking about this trade-off between consumer affordability and what they pay out of pocket and their families pay out of pocket, and then what is coming from, largely we've been talking about federal budget, although Joanne, of course, also mentioned that some states have chosen to sort of enhance subsidies. I mean, Liz, you've been in those rooms where the debates are happening. I mean, do you see this as just like, how fundamental is this to challenges to finding consensus? How do you see policymakers, particularly on a hopefully bipartisan basis, like ever addressing it? The fundamental trade-off between, sort of public taxpayer dollars going into subsidies versus what individual households and individuals are paying.
Yeah, I would say it's a challenge. I think that, as I mentioned before, I think of all of the different health policy issues that I've worked on, these issues are very different because of the politics surrounding the Affordable Care Act. And it is amazing to me, having been on the Hill during that time, And listen, I worked for a Senate Republican during that time, so it's not, so I understand, you know, during that time, the policy concerns. It still shocks me that today, though, we're still operating from a perspective where we're kind of still at that loggerheads of like, are you for it or are you against it? And I think it was 2016 when you started to see when cost sharing subsidies weren't going to be paid, and you started to see some counties that were likely to not have insurers on the market. You started to see a little bit of a panic of some, I think, Republicans in Congress, with an understanding that no private insurance in their district was actually not a good outcome. And you saw them kind of band together, and then, you know, some situations changed, and there was no longer this moment. So I think there has to be a confluence of things. I mean, I think it's hard when either party is talking about doing something through reconciliation and it becomes this like kind of, you know, big political moment. It becomes a lot harder to have some of these real world conversations, but the conversations are ongoing. And so I think affordability to me is really kind of the next real theme, both individual market, employer market, really addressing people's out-of-pocket costs, I think is going to really dominate, you know, almost everything that Congress does on healthcare in the next 2 years. So I think in the confines of that affordability conversation, I think there's definitely room, you know, for some consensus and to move forward.
Thank you so much. Kevin, from the state policymaking perspective, you know, how do you see this? I mean, you're hearing from families every day. Where do you see a sort of path through here?
Oh, it's tough. I mean, you know, one, we have combined federal tax credits and health insurance to create this Frankenstein, right? This very complicated monster that families are supposed to figure out. And then we say, we explain everything in federal poverty level numbers. People don't know what that means. They're trying to figure out how to work per hour. We converted everything that we send out, especially like the restaurant workers, other folks that we know work hourly jobs, to what the hourly rate is for all of that, to try to figure out, because they know how much they make an hour. They don't know how much they make a year because they don't know how many hours they're going to work. And so really trying to change this conversation in a way that the average person can understand what their choices are. And a lot of the work that we've been doing is trying to make those choices more reasonable for them to figure out, because, you know, the great thing in Colorado is we added almost 100 new plans on the exchange. The bad news is we added almost 100 new plans on the exchange, and it's just tough for folks to kind of figure out how to wade through all of that. And so we're trying to ask 3 to 5 questions up front to kind of limit what they need to see, so they can say, okay, I can handle this number of choices that are close to me, that have the pharmaceuticals I'm looking for, the doctor, the network, whatever they need to find. And so I think with all this conversation we have about all this stuff that's moving around us, not to lose sight of what the customer needs to know to make a decent decision for their families, to actually get the dadgum health insurance and use it.
Yeah, thank you. And that leads right into the next question, actually, which is around this idea of choice. And of course, you know, we often talk about consumer choice as something people really like as a kind of a core value, but then also obviously, like, you have to help people navigate those choices. We have a question, which is, can the speakers talk more about standardized plans and sort of, you know, hey, I thought there already were standardized plans. We already have like the gold, silver, bronze, et cetera levels. Can you give a little bit more specificity about what you mean by standardized plans? And Kevin, I don't know if you want to start off with that, and then I'll turn to Joanne and to Sarah and Annette and Liz to weigh in.
Oh no, I'm punting to Joanne on that one.
Joanne?
I will be on a diatribe. It won't be helpful.
So yes, I mean, I think there is some level, at a basic level of standardization with the metal, you know, that it was intended to make it easier for people to do apples to apples comparisons. I'm looking at the silver level, I'm looking at the gold level, but this takes it a step further to really lock in cost sharing for particular services. And in many cases, as I said, make more services available without having to meet the deductible. Primary care, behavioral health are often services made available before the deductible with standard plans, to set cost sharing for other services, and to prioritize co-pays over co-insurance, which it's easier for consumers to understand what their out-of-pocket costs are when they're looking at a dollar number instead of 20% of some unseen, cost that may show up on their bill one day. And they used to be in the healthcare.gov marketplace as an option for insurers. What the feds are proposing now is to require it of all insurers that are offering QHPs in healthcare.gov. And as I said, states have been doing this for some years now. And it's both to help with that decision making, but also to make coverage more affordable and people to, more easily understand what their out-of-pocket costs are. It does, as proposed in the federal rule, dramatically increase the number of plans, because the rule is for every QHP you offer in a metal level or product type like HMO, you also have to add a standard plan. And so they've also asked for comment on whether or not they should limit the number of plans, if they should require meaningful difference so that there aren't these minor differences between plans that consumers can't actually distinguish between. And they've also proposed to tighten the de minimis variation on AB plans. So a 70% plan can actually be anywhere from 66 to 72. They're proposing to sort of bring up the bottom end of that. So it has to vary between 70 and 72%. And that's a narrower variation when you're looking at a silver plan.
Thanks. And so just to clarify, you're talking about, first of all, the percentages you just mentioned, you're talking about actuarial value.
Yes.
Correct. Okay. And then the rule you're talking about is the proposed notice of benefit and payment parameters that was released, I believe, I want to say December 23rd or something like that of last year. So, so that's an active rulemaking in progress. I think someone earlier had also asked, like, what's going on at the federal level. That is something, and we can send around that link for those who are interested in some bedtime reading, the notice of benefit payment parameters. And then lastly, Joanne, just for those who are kind of maybe a little newer to health insurance terms, this idea of copay versus co-insurance, like $20 versus 20%, right? Like a flat copay versus a co-insurance. Okay, so anyone else want to chime in on that question of standardized plans or anything?
I'd like to chime in. I'm not sure how helpful I'd be, but the thing is with standardized plans, and Joanne mentioned, some of the concerns or the some of the concerns. One is, as she said, is that you add more plans. That's not helpful, right? The other thing is that I think we all know that health is local, and so the extent to which these standardized plans reflect what the needs are or the specific circumstances of an area, even within a state, I think that would make it more helpful to the enrollee population. The use of standardized plans in the states that have implemented it has been quite low. And in those states where they limited the number of plans, the number of non-standardized plans, that's where you see more effective take-up. So those are some considerations. And as far as health equity, it's not clear that adding standardized plans would help the goals of health equity, unless it is done in a way to focus on the inequities and where the benefit design would, or the change in benefit design would impact health equity. So those are some things as states are starting to think about standardized plans in their markets. Those are some things that may be considerations.
Thanks. I want to ask you kind of an impromptu question here, which is just, I mean, it feels like sometimes this conversation is like, the government is setting standards, whether the federal or states, the health insurance plans. Of course, we haven't talked about the role of providers at all, but and then we're trying to like explain it to consumers. Like, is anyone making an effort to actually ask people, you know, the end user, the consumers, like what they think and what would actually be useful and clearer to them, and then trying to incorporate that into the design. I don't know if anyone wants to try to respond to that, but I am curious if there have been efforts along those lines.
You know, I can't speak to the kind of direct outreach to consumers. I will say that in kind of the confines of our kind of enrollment coalition work, there's a number of different kind of patient advocacy groups that are engaged in that work. And I think in general, I have to say, I think the administration has been really open and interested in hearing from people that are kind of on the front lines about what works and what doesn't work. And so I'll just also put a plug that, you know, whether it's commenting on the notice and benefit and payment parameter rules or other opportunities to really engage with policymakers, I think it's really important because particularly at a time when a lot of policymakers aren't hearing really practical ideas, I just think it's so important that they're hearing from people on the ground about what is and isn't helpful.
Thanks.
Early state efforts really struggled with displaying standard plans in a way that consumers could find them. I mean, this is not directly your question about what do consumers want in that specific plan design, but even just the presentation of them, I know was not well done in the beginning, and I think states have really evolved from there, and the feds are asking as part of this proposed rule, what should we be keeping in mind about display and helping consumers understand what this standard plan is and how to find them.
Thank you. And I saw Kevin kind of nodding along to that as well. Anything you wanted to add or?
Yeah, I think sometimes we think we know what the customer wants, but when we ask them, we actually find out what we didn't think to ask. And I think, you know, we've learned a lot of that on how we've just done changes on our plan design and how we're making changes to the shopping platform. And I think, you know, going back to something I said a little earlier, you know, if people don't really understand this whole structure, you know, making an assumption of what we think because we know the policy really well is a pretty dangerous place for us to start. So I think making sure that we have as much effort to talk to them, the customer, about what they care about, and then finding a way to translate that into the language we're used to and framing it in that way is got to be it just has to be the way we start.
Yeah, thank you. Sarah Collins, I want to bring you into the conversation, and I'm curious, like with your researcher's eye and ear, like what are you thinking is important to look for as you sort of think about, I don't want to say calculating these trends, but I mean, you've been looking at this now for at least 10 years, if not like many, many more, and sort of tracking this stuff. I mean, from a researcher's eye, like what's popping for you in this conversation?
You know, I agree. The standardized plans is such an important thing to do, and particularly to focus on deductible exclusions and making it easier for consumers to choose. But I think that the part that we haven't addressed and what we really need to address is the fact that people are facing really high deductibles in a lot of these plans in the individual market. The cost sharing subsidies are fantastic, but they're only for people under 200% of poverty, or 250, but they're even between 200 and 250, it's pretty high. The deductibles are pretty high. So we really have to get at that. And there are bills in Congress to extend the subsidies further up the income scale. But it's a big issue, and it's an issue in employer plans too. And the one thing I do want to point out too, just as a reminder to the audience, is where these costs come from. You know, when we talk about the tax financing and then what consumers pay, this is really a problem of healthcare cost growth. And it's, if we continue to see excessive growth in healthcare costs, which is primarily driven by provider prices, we're always going to be in this situation where we're trying to decide how much taxpayers pay of this ever larger bill and how much consumers have to pay out of pocket. So I think there's just some overarching cost issues here. The public option debate gets at that, but it's a hard issue, and it's one we're going to continue to grapple with when we talk about affordability. There are underlying drivers that we've really got to address.
Yeah, thanks, Sarah. Go ahead, Joanne.
Well, it just reminded me, I mean, putting that together with the standardized plans and copays, you know, we've heard from states where they have copays, they may have to adjust them the next year because the cost increased behind it. If you do a co-insurance, just the consumer's cost grows with the underlying cost growth. But though consumers prefer the copay, this unrelenting trend in cost growth means that states that have standardized plans have to go back and tweak them year to year, because what fit in the math of the actuarial value one year with $20 copay no longer works the following year.
Yeah, thank you. And I want to ask just one question that came in from the audience that gets a little bit to this question of underlying costs, and it's for Annette. Are you looking at the actuarial impact of COVID delayed treatment? So for example, those non-COVID related things that haven't been treated. Are you looking at the high death rates among seniors? What are the actuarial impacts of that, as well as long COVID? How are you beginning to think about that?
Yeah, that's a really good question. So that is something that we are looking at. The data is not conclusive right now. It's still evolving, and it depends on the different areas of the country. You have different impacts, but that is something that I think health plans are going to have to factor into their costs, and because we don't know what the impact of long COVID is. We don't know the extent of it yet. And when COVID was mainly impacting the elderly, one could say that the time frame for that is fairly short. But now that COVID is impacting younger and younger people, the time frame for the impact and the extent of the impact could be really significant. So we're looking at that, but quite frankly, we don't have enough data yet to understand exactly what that means. But that is something that's very troubling. And then you mentioned the foregone care. We're seeing increases in mortality in certain areas for non-COVID reasons, and part of that is the foregone care. And so, that is also very troubling. What is that going to look like, and how deep is that impact, and how long is that impact going to be felt? That's not helpful for trying to manage the costs of healthcare. But those are things that we're looking at, and honestly, we don't have any answers right yet.
Yeah, thank you. And I suspect we'll be spending quite a few of the next several years really unpacking and trying to better understand the impacts of this pandemic, and as we hopefully turn the corner and emerge from it, but certainly still requires very good data and an objective look and thoughtful discussion, including from people like yourselves. You have been amazing panelists today. Thank you so much. We have just 1 minute left, so we don't have time for any more substantive questions, but we are so grateful to Kevin Patterson, Director of Colorado Health Benefits Exchange, Liz Rowe of Levitt Partners, Annette James, American Academy of Actuaries, and Joanne Volk from CHUR, Center on Health Insurance Reforms at Georgetown, and Sarah Collins from the Commonwealth Fund. We are grateful for your partnership, really grateful for your incredibly thoughtful remarks. And I hope that our audience has taken away some new learnings from this. Again, you'll be able to watch a recording of this discussion on our website as soon as the technology is ready. And the materials will be on our website at allhealthpolicy.org. So please take time to complete the brief evaluation survey you'll receive and share your thoughts with us, as well as your wishes for future topics for us to cover, and join us next Friday, January 28th, for the next event in our Health Policy Roundup series, focusing on state policy analysis and priorities, and get a better sense of what's been going on in the states. So again, thank you. This concludes today's webinar on recent trends in coverage, enrollment, affordability. Joanne, Patrick, Annette, Liz, Sarah, thank you for joining us today.
Thank you.
Thank you.